Okay, well, we'll go ahead and get started. Good morning, everybody. Welcome to our Sweatland Seminar Series, which highlights our center's three-pronged approach related to research, training and education, and community engagement. Before we get started with today's seminar, I want to acknowledge the history of the land that our campus resides on and actions leading to the land officially being ceded by chiefs and warriors of the Native American tribes listed here through the signing of the Treaty of Greenville in 1795. We are grateful for their stewardship of this land and honor these groups in the work that we conduct here. So I have a few housekeeping items to go through before we get started as well. So please note that you are all muted. If you have a question or a comment throughout the seminar, please feel free to utilize the chat function. I will be monitoring that as well. So hopefully we'll be able to get any of your questions answered. I am recording the seminar today, so we'll be posting the recording on our Sweatland Center website by the end of the week. So to get started, please feel free to use the chat feature. Let us know who you are and the organization that you represent. And I'd also just like to remind everyone that our center will not be hosting a seminar next month for December. So we do invite you to check back on our website to register for our upcoming seminars. I'll be linking our center's event page in the chat box for you so you know exactly where to find all of our upcoming events. So we do have some really exciting seminars planned for next year, including an in-person visit to Renal Farm, an outdoor ecotherapy session, which will include a hike near the Dome Brook watershed and a guided meditation session, and then a documentary viewing and Q&A session about Cleveland's healing spaces. So those are just some of the upcoming seminars we have planned for everybody next year. So we hope you'll join us in 2022. And lastly, before we get started, I'd also like to mention that we are seeking your feedback about our Sweatland Seminar Series. So we're always looking for ways to improve our seminars and bring you presentations that you're interested in. So we'd like to invite you to fill out a brief optional survey after our seminar is finished to gather your feedback. I'll be putting the link to a short optional survey into the chat box for you to complete at your earliest convenience, and all of your answers will be anonymous, and we really appreciate your feedback to consistently keep improving our seminars. Okay, so let's go ahead and get started today. I am pleased to welcome Dr. Ash Sehgal. He is the Duncan Newhouser Professor of Community Health Improvement at Case Western Reserve University and is the co-director of the Center for Reducing Health Disparities. He's a nephrologist and the Director of Research and Evaluation for the Institute for Health, Opportunity, Partnerships, and Empowerment at the Metro Health System. So I'm going to go ahead and stop sharing my screen so we can get started with today's presentation. Thank you so much for joining us today, Dr. Sehgal.
Hi, good morning. Thanks for the invitation and for that nice introduction. Can everybody see these slides okay?
Yep, looks great.
Okay, great. So I'm going to be talking about the carbon footprint of a life-sustaining treatment, specifically chronic hemodialysis treatment. I want to start by acknowledging my collaborators. Ann Hummel is a nephrologist at the Cleveland Clinic and also a faculty member in the Center for Reducing Health Disparities. Jonathan Slutzman is an ER physician at Massachusetts General Hospital. And then I also want to thank the dialysis facilities that participated in this project. So there's three ideas I want you to take away from this presentation. The first is that health systems themselves contribute to climate change. The second is that hemodialysis treatment has a large carbon footprint. And the third is that variation in dialysis-related emissions may provide us an opportunity to reduce its environmental impact. By the way, feel free to jump in along the way if you have any questions or comments. So here are the, 7 things I'm going to talk about. I'll start off with mechanisms of climate change, then talk about the health impacts of climate change, some background about end-stage renal disease and hemodialysis. Then I'll tell you about the study that we did, its results, its implications, and then some final thoughts. So let's start here with mechanisms of climate change. So this is a simple way to think about the mechanisms of climate change. So basically what happens is that solar energy or solar radiation comes in from outer space into the atmosphere. That solar energy is absorbed by the Earth's surface, but then some of that energy is radiated back towards space. Now, the key here is that this radiation back towards outer space occurs at a longer wavelength, at an infrared wavelength, compared to the incoming solar energy. And it turns out that carbon dioxide and other greenhouse gases absorb some of this infrared energy and limit the radiation back into space. That's depicted by this arrow here, and that results in a warming or increase in the temperature of the surface of the Earth. Now, there's an urgency for us to understand and address climate change because carbon dioxide levels have already increased from 280 in pre-industrial times to 413 currently, so about a 50% increase in carbon dioxide levels. To limit further adverse effects of climate change, we need to cut carbon emissions by 50% in the next decade and be carbon neutral by 2050, meaning no net addition of carbon dioxide into the atmosphere. So that's the mechanisms of climate change. Now let's talk about the health impacts of climate change. These are some of the main hazards of climate change: increased temperature, wildfires and air pollution, storms and floods, and droughts. So I mentioned when I was talking about the mechanisms about why we get an increased temperature. Well, an increased temperature can lead to dehydration, fatigue, heat stroke, and kidney disease, among other problems. This is especially an issue for people who have to work outdoors in hot climates, such as the farmers in this photograph in El Salvador. Higher temperatures also increase the risk of wildfires, mold, pollen, and other pollutants. You wouldn't be surprised to know that air pollution worsens asthma and allergies, but it turns out that air pollution is also a very significant contributor to cardiovascular disease and mortality. This photo is a wildfire in Australia. The warming that results from climate change increases evaporation, and in some places this can result in more storms and more floods. This is a photo of Hurricane Maria as it was approaching the island of Puerto Rico. This hurricane resulted in many injuries, deaths, and adverse effects on mental health. The evaporation that's associated with climate change causes storms in some places, but can cause droughts in others. And these droughts reduce freshwater supplies and agricultural production, which can lead to malnutrition and diarrheal diseases. So here's a photo of a drought affecting a cornfield. Now, climate change also has an effect on healthcare systems because it changes the prevalence and geographic extent of illnesses. Climate change and associated extreme weather can also disrupt utilities, transportation, and communication systems. Here is a hospital that was flooded in New Orleans due to Hurricane Katrina. Now, not only are healthcare systems going to feel the brunt of these climate hazards, but it turns out that healthcare itself contributes to climate change because in the United States, the healthcare sector is responsible for about 10% of all the greenhouse gas emissions that occur. So in other words, healthcare has a very sizable carbon footprint. So that's a little bit about the health impacts of climate change. Now let me give you some background about end-stage renal disease and hemodialysis to set the stage for the study that we did. So there are about 800,000 Americans who have end-stage renal disease, which is a permanent and complete kidney failure. So permanent means that there's nothing that we can do to get the kidneys to start working again. And complete means that the extent of kidney failure is so profound that these patients need a life-sustaining treatment in order to continue to survive. And there's two choices. Patients can either get a kidney transplant, as depicted here, or they can get dialysis treatment. The most common type of dialysis is hemodialysis treatment that's shown in this photo. So there's a patient getting hooked up to a dialysis machine. Here's a diagram that illustrates what happens in a hemodialysis machine. So in a hemodialysis machine, blood is removed from a patient's body. It's run through a dialyzer or a filter that removes excess fluid and waste products. In other words, it mimics what the normal function of the kidneys would be. And then the blood is returned back to the patient after it's been cleaned and removed of excess fluid. And you can see from this diagram that there's lots of pieces and parts to this hemodialysis machine, including blood pumps, heparin medication that's used to prevent the blood from clotting while it's outside the body, a clean fluid called dialysate that helps the dialyzer function, various monitors and air traps. We already know from other work that hemodialysis treatment has a high environmental impact compared to other types of medical treatment. A typical patient will have a 4-hour hemodialysis treatment 3 times a week. It's estimated that there are about 240 liters of water that are used per treatment. A study from Australia estimated that the electricity for one hemodialysis treatment was the same as the electricity for an entire day for an average household. And a study from Britain estimated that there were 6 pounds of hazardous waste generated per hemodialysis treatment. Let me just stop there and see if anybody has any questions about anything I've said so far. So in that case, let me tell you now about the study that we did. Our study had 2 questions. The first is, what's the magnitude of the carbon footprint of chronic hemodialysis treatment? And then the second question is, what are the sources of variation in this carbon footprint? So we did this study at 15 hemodialysis facilities, Northeast Ohio, and we collected data for calendar year 2020 for this study. These are the data elements. So we collected information on electricity, natural gas, and water use from utility bills for these facilities. We collected information about supplies that were used in the course of providing hemodialysis treatment. There's about 3 dozen different supply items that are used, ranging from syringes to blood tubing sets. We also obtained information on patient and staff travel. So patients typically travel from their home to the dialysis facility 3 times a week, and staff or employees, if they're working full-time, would be traveling from their home to the dialysis facility 5 days a week. And so we obtained information about the distance traveled and the mode of transportation, whether it was an automobile or a van or a bus. We also obtained information on the waste that was generated, and also whether it was a biohazard waste that was incinerated or landfill waste. And then we did some analyses to estimate what are the greenhouse gas emissions related to each of these items. So how do you estimate greenhouse gas emissions? Well, what you do is you multiply the actual usage of a fuel or a supply item by what's called an emission factor. So an emission factor is the amount of carbon dioxide that's produced on average per unit of fuel consumed or material processed. And the emission factor includes in it the impact of other greenhouse gases, such as methane or nitrous oxide, and they're included as carbon dioxide equivalents. So as an example, if you use electricity in Northeast Ohio, the emission factor for electricity is 0.533 kilograms of carbon dioxide equivalents per kilowatt hour. So if you used 1,000 kilowatt hours of electricity, and that you would expect that on average that would generate 53.3 kilograms of carbon dioxide equivalents in terms of greenhouse gas emissions. For supplies, we had to do something a little bit different. We disassembled, actually, Ann Hummel disassembled the supply items into their components. And then we obtained emission factors for each component. And then we summed the emissions across components. Now, we don't actually use dental floss during hemodialysis treatment, but I like this picture because it illustrates how we can disassemble items into their components. So here is a container of dental floss, and you can see that after you disassemble it, you're left with separate items that are all made of the same, that all have the same composition. So here is one type of plastic that's used for the housing. Here's a separate type of plastic that's used for this little window here. Here's the dental floss here. And then here is a little metal tab that goes right there and is used to tear off a piece of the dental floss. So we did this, except we did it with all the supplies that were used during hemodialysis treatment. Here's an example that's specific to this study. So remember I said a dialyzer was the filter that's used to remove waste products and excess fluid. So here's a photograph of a dialyzer. And so what we did is we separated the dialyzer into its components and then weighed the mass of each component. So one of the components is fibers. So those are the fibers in here. So we took out the fibers, weighed those, and then we got from the manufacturer's specifications what the fibers were made of. Same thing for potting material. You can't see it, but the potting material is up in here and down here and here, and that holds the fibers in place. So we weighed that and we figured out what that was made from the manufacturer specifications. Then there's a housing, that's the plastic container that holds the fibers and the potting material. There's these little caps. And then this whole dialyzer, you can't see it, but it comes in a plastic bag or an outer wrap that's made out of polyethylene film. So at the end of this disassembly process, we know exactly what the different components are that this dialyzer is made of and what each of those weigh. Then we can find the emission factor for each of these things, apply it to this weight, and then add the whole thing up, and then we'll know what the emissions are related to a dialyzer. For travel, we looked at the distance traveled and then the mode of transportation, and then we obtained emission factors from the Environmental Protection Agency's database for what the emissions are on average for, say, driving an automobile a certain distance or driving a van a certain distance. And we also used the EPA's data to look at what the emissions are on average for biohazard waste and for landfill waste, depending on the weight of the waste that's generated. So that's how we did the study. Let me see if anybody's got any questions about anything I said there.
Ash, I had a question. This is
Sure.
Dark. You said 50, you made the comparison 1,000.
Kilowatt hours.
Yeah, and it was 53.3. How does that translate out? Like, what is 1,000 kilowatt hours? Is that a lot? 53.3? Is that, each individual? Just if you could give some context to those numbers.
Yeah, that's a good question. And I will show a little later a way that we can think about these large numbers in terms of things that we might have a better sense of, for example, driving a car or energy use for a house. So I'll get back to that. That's a good question. Anybody else? Okay, so let me show you our results now. So here is a table that summarizes the data that we obtained from the 15 dialysis facilities. So I'll just stop for a minute and let you take a peek at that. So you can see from here that the average dialysis facility had delivered about 14,000 treatments over the course of a year. And then this is on average what the electricity use was per facility. And then you can see down here, we've got gas, water, all the way down to how much landfill waste was generated. Again, this is the average value for each of the 15 facilities over the course of 1 year. And now this is the same type of information, but now instead of showing you kilowatt hours or kilograms or things like that, everything's been converted to estimated greenhouse gas emissions in terms of kilograms of carbon dioxide equivalents. And so I'll wait again for a minute and let you take a look at that. So again, you can see lots of big numbers here. The total is 870,000 kilograms of carbon dioxide equivalents per year per facility on average. And you know, carbon dioxide is a gas, it doesn't weigh a lot. So 870,000 kilograms, that's a lot of carbon dioxide. And then here we have the contributions from each of these different sources, from electricity down to landfill waste. And then I've got what the percent of the total is. So you can see that the largest contributors to total greenhouse gas emissions are electricity, natural gas, transportation, and landfill waste. Now, there's a lot of differences across these 15 facilities and how big they are. Some of them only have a relatively small number of patients. Some of them have hundreds of patients. And so if you're interested in looking at variation, it'd probably make more sense to look not at what the total is for each facility, but to kind of adjust for the number of patients or the number of treatments that they deliver. So this slide here shows the same type of information as the last one, but now it's not emissions per facility, but it's emissions per hemodialysis treatment. Again, it's in kilograms of carbon dioxide equivalents. And now I've got on here is the mean values and the range. So the range refers to the facility that has the lowest value to the facility that has the highest value. And again, I'll stop just for a minute so you can look at that. So now you can see that on average, there's 66 kilograms of carbon dioxide equivalents generated per hemodialysis treatment. And then here's what the different contributors are. But now what I want you to focus on is also the range. So there, even though on average there are 66 kilograms of carbon dioxide equivalents generated per hemodialysis treatment, there's a big range. There's facilities that only generate 37 kilograms of carbon dioxide equivalents per treatment, and others that generate 105. So there's a threefold variation in the carbon footprint across facilities. And then if you look at these individual items, there's also a lot of variation. So there's like a threefold variation in electricity use, an eightfold variation in natural gas use, a fivefold variation in water use across these facilities. And I thought this was very surprising when I first saw this, because, you know, these are facilities that are all basically providing the same kind of treatment. It's all hemodialysis treatment. You know, there's a little bit of variation across patients in the duration and some of the other details of the treatment, but not that much, not something that would explain 3 or 5 or 8-fold variations. So they're really essentially giving the same treatments, but there's all this variation. It's also all in a single geographic region. It's all in Northeast Ohio. It's not like we're comparing facilities in Northeast Ohio with facilities in California. And these dialysis facilities pretty much only provide hemodialysis treatment. They're not also doing, you know, like surgery or outpatient care. And they're all part of the same organization. So they're not parts of different dialysis chains. So it's very surprising to me that in spite of the fact that there's all these similarities, we're seeing so much variation across the facilities in their carbon footprints, both the total carbon footprints and individual contributors to those carbon footprints. this is another way of looking at the same results. So across the y-axis here, I've got the emissions per treatment. And then you can see that electricity and patient and staff transportation and natural gas and landfill waste all have high emissions per treatment. But now across the x-axis, I've also got the coefficient of variation, which is an indication of how much variation there is across facilities. And you can see that there's a lot of variation in transportation, natural gas, and water use across these facilities. So from a quality improvement perspective, if you wanted to try to intervene and try to reduce the carbon footprints, you could go one of two different ways. One way would be to go after the big ticket items, right? These are the ones up here, and try to reduce the emissions related to electricity and transportation. Or another way to go would be to focus on the things where there's a lot of variation. Because if there's a lot of variation, then maybe you could figure out what's happening at the facilities that have low emissions and use that as a model to help reduce emissions at the other facilities. By contrast, the things that are in this corner that are that have low emissions and also low variation might be things that you want to focus on later on once you get some of these other things under control. So here's the main findings, and this gets at one of Darcy's points. So one of the main findings is that hemodialysis treatment has a sizable carbon footprint, and the annual emissions per facility are the same as the annual energy use of 102 average homes. So one facility is like 102 homes. And then the emissions per hemodialysis treatment is the same as driving an average automobile 162 miles. So I think that's like from going from here to Dayton, Ohio. Another main finding is that these are some of the largest contributors to total greenhouse gas emissions: electricity, transportation, and natural gas. Another main finding is the substantial variation that I pointed out. So there's a threefold variation in emissions per treatment across the facilities, eightfold variation in natural gas, fivefold variation in water use. Okay, so now let me talk about some of the implications, what I think are some of the implications of these results. Well, let me just stop there first and see if anybody has any questions or comments.
I actually have a question. This
Sure.
is Lindsay. So I know you kind of went over the basic structure of like a hemodialysis machine, and I'm assuming that that's probably consistent across all of the facilities, that it's, you know, pretty much the same. But and I don't know if maybe you mentioned this, and I apologize if I missed it. Were like the actual machines used, like, were they different brands, or like kind of like, was there variation in like the machine in any way, or were they all using exactly the same like model of hemodialysis machines?
Yeah, that's a great question. So I believe that these facilities have two different types of machines that they use. And so I can go back and see if that made a difference in their in their carbon footprint. So that's a good point.
Great, thank you.
Anybody else?
Yeah, it's Marcia. Could I just see the graph of the variation again? That one. Water looks very tight there, but in the last slide you told us water was the part that had a lot of variation. So I'm confused.
Yeah. So the variation is depicted on the x-axis. So water has a coefficient of variation that's like around 37 or 38%. And so that's a fairly large amount of variation. It's a little confusing. I'm still struggling with how to present this, but these error bars tell us how much confidence we have in the estimate of the emissions per treatment, which is different from the variation.
Oh, okay. Thank you.
Sure. But a good question, and it sort of pushes me to think more about how to present this. Anybody else?
Actually, Ash, kind of going back to that same slide again. So the wide variability, like water is very consistent. It looks across for one treatment, but different places have variability. But like something like electricity, emissions per treatment fairly, this is just total emissions. There's still a pretty big range. And I'm just wondering, is it like newer equipment is more efficient than older equipment, or what might be driving some of the, like transportation makes sense because people are coming from different distances.
Mm-hmm, mm-hmm. Yeah, so that's a good question, and that would be the next thing to do on this topic, right? Would be to figure out what's driving this extreme variation that we observed. So we haven't done that yet, and at this point, it would be just speculating about what might be driving this. I did look in preparation for this talk. I did look to see if there was a relationship between volume and emissions. You know, in other words, do the big facilities that have lots of patients and lots of treatments, do they have lower emissions per treatment compared to smaller facilities that just have a small number of patients and therefore a smaller number of treatments? And it didn't seem like there was much of a relationship between the volume and the emissions. Anybody else?
Hi, my name's Lauren. I'm from Swellen Center as well. I just had a question. It's not really about your presentation, but just this research is really exciting to me, kind of this challenging of hospitals and the practices. Is this like a pretty novel study, like looking at the impacts of this work? And are hospitals looking at all to reduce their impact on climate change?
Yeah, that's a good question. I think it's fair to say that most hospitals are doing something to try to understand and hopefully address their contributions to climate change. But it's really a field that is at its infancy. So there's certainly a lot more that needs to be done. And in terms of hemodialysis in particular, there have been 3 previous studies, one in the United Kingdom, one in Australia, one in Morocco, that quantified the carbon footprint of hemodialysis treatment. But I haven't seen anything either in hemodialysis or in other aspects of healthcare that tried to look at variation and sources of variation.
Great, thank you.
Any other questions or comments? In that case, let me tell you what I think are some of the implications of these findings. So what could we do as a result of these findings? Well, one of the most important things we could try to do would be to try to prevent end-stage renal disease from happening in the first place, right? If we can prevent end-stage renal disease, then we don't need to do hemodialysis treatment, and then we don't have all those greenhouse gas emissions related to hemodialysis treatment. And so we could do that by screening for and managing kidney disease and also its common causes, namely hypertension and diabetes. We could make sure that patients who have early stages of kidney disease avoid drugs that might further damage their kidneys. There are certain types of medications called angiotensin inhibitors that seem to be especially good for people who have early kidney disease and are spilling protein into their urine. And then we also know that smoking cessation is a good way to prevent progression of kidney disease. Another thing we could do is to examine and try to reduce all this variation that I described. So as I mentioned, we could look at processes at more efficient facilities as models for other facilities. And I think that large dialysis chains would be especially suited for this kind of work, because large dialysis chains by definition have lots and lots of dialysis facilities in their organization. They probably will have lots of variation, and they'll have also the resources to try to do something about it. There's also these regional quality improvement organizations called end-stage renal disease networks that I think should also get involved in this area. And I think in general, we should start thinking of the carbon footprint of healthcare as an additional quality of care marker. A third thing we can do is to pay particular attention to large emission contributors. So just as an example, landfill waste was one of the larger emission contributors. And if you want to do something about that, then you could do a waste audit to identify areas for improvement. You could try to make sure that you're recycling all the recyclable products. You could order supplies with minimal or recyclable packaging, and you could dispose of waste locally instead of transporting it long distances, because the transportation itself will have its own carbon footprint. And then finally, you can purchase electricity from renewable sources like solar or wind. You can use electricity instead of natural gas for heating. You can shift to electric vehicles. If we did all of these things, that would dramatically reduce the current emissions from electricity, natural gas, and transportation, because then the electricity would be coming from renewable sources, not from coal. Instead of natural gas, we'd be using renewable electricity, and instead of gasoline, we'd be using renewable electricity. Here's some limitations of this study. We focused only on one dialysis chain, only a single geographic region. Now, I wasn't able to include medications that the patients received during hemodialysis treatment because pharmaceutical companies do not share their emission data with outsiders. I also did not include recycled waste just to keep this analysis simple. It turns out that there's only 1 out of the 15 facilities that does recycling, so I don't think that that made a big difference in the numbers that I showed you. I also ignored emissions related to assembling the supply component. So in the dialyzer example, I have the emissions separately for fibers, for potting material, for housing, for caps and wrap, and I just added those all together, but I didn't take into account the energy or work that's required in that assembly process. And then I told you about the transportation so for the patient transportation, we had information on the mode of transportation, whether it was car or van or bus. But for staff, we didn't have the mode of transportation, so I just assumed that they all traveled by car. So those are what I think are some of the implications of this study. Let me stop and see if anybody has any questions or comments before I share with you my final thoughts.
So are you going to talk about home dialysis as an alternative, Ash?
I wasn't, but maybe if you want to talk about it during the discussion, that would be great.
Okay, thank you.
Thanks. This is Rosa. Can you hear me?
Yes, faintly.
Okay. Can you talk about how this study actually worked in terms of getting information from the patients? Did you consent them, or was it exempt? How did you get the information about the patient's mode of transportation and distance?
Yeah, that's a good question. So we first obtained IRB approval to do this study. We also obtained approval from the participating facilities to do this study. Within the electronic medical records of the facilities is information about where the patient lives and the mode of transportation they use to get to and from the facility. And so we used those data.
Interesting, thanks.
Anybody else?
I have a question. So, I mean, this is a really interesting study, and you kind of listed what we can do. And, you also mentioned that this is like a really new study, and, not many people have done this. So when can people start seeing, the list that, early testing, and I can't remember those, maybe in the couple of slides previously that you mentioned what we can do. How soon can the hospitals start implementing the changes, or how soon can they start, or have they already started those early recognitions of these things?
They're all at different stages. So that some hospitals are very far ahead, and others are just starting to think about this. Some of the things could be done within a matter of a few weeks. Some of them would take a few years to happen. So it's really very variable. Anybody else? Okay, well then let me just share a few final thoughts, and then we can have more of a discussion. So again, I'm just repeating my initial slide of what I wanted you to take away from this presentation, which is that we're contributing to climate change ourselves in the health system, that hemodialysis has a large carbon footprint, but that there's all this variation that might provide us an opportunity to reduce its environmental impact. Now, in the context of climate change, there's these three terms that you might see. So there's mitigation. So mitigation means doing things to reduce carbon dioxide emissions. So for example, if we shifted from electricity that comes from coal-fired power plants to electricity that comes from solar or wind, that would be reducing carbon dioxide emissions. So that'd be an example of mitigation. Adaptation means, again, in the context of climate change, means trying to adjust to the effects of climate change. So for example, if we told our asthmatic patients how to go online and monitor outdoor air quality, and then either stay indoors or wear a very good mask if they have to go outdoors on a poor air quality day, that would be an example of adaptation. And then we all know what suffering means. So unfortunately, these are the three things that are in our future: mitigation, adaptation, and suffering. And it's up to us to figure out and to work hard to influence what the relative proportion of these three things is going to be. And of course, I would want us to work as hard as we can on mitigation and adaptation so that we can limit suffering. So if you're interested in this topic, you could pick a climate hazard or a health impact that you're interested in, review what's already been done, and then decide where you can contribute. You might want to educate the public or policymakers or health providers. You might want to implement programs in your practice or health system. You might want to conduct research to address gaps in our knowledge. And most importantly, I think we need to, as citizens and consumers, push our government and corporations to dramatically reduce our carbon footprint. We already have the technology to do that. The prices of electricity from renewable sources are already competitive with or even cheaper than the prices of electricity from fossil fuels. But we need the movements and the political will to make that transition as quickly as possible. And then this is my final slide. These are some resources that I find helpful. There's an organization called Ohio Clinicians for Climate Action that's doing really good work. There's a new journal that I'm on the editorial board of that focuses on climate change and health. It's available for free online. And then there's 3 weekly newsletters that I subscribe to, and you can just Google them and subscribe to them as well, and you'll get an email every week summarizing what the latest developments in the field are. And then finally, there's my email address. You're welcome to contact me with any questions or if there's anything I can do to help. So I'm going to stop sharing and be happy to hear your comments and questions.
I have a question. Can
Go
you hear me?
Yeah.
When designing the study, did you take any demographic information of those with renal disease?
We do have demographic information about the patients at these 15 facilities, but I didn't include it in the analyses because I wasn't sure how it would be relevant. But if you have some ideas, I'm open to your suggestions.
What's the possibility of reduction? Please excuse me, this topic was very triggering because I did care for an uncle who was on dialysis for 10 years. What's the possibility of reduction coming in the form of patients being denied this care if, hospitals were looking at this data in terms of, reducing their carbon footprint? Is there any opportunity in the future that it could be used to deny people that are in, that have these health disparities, the care that they need?
Yeah, that's a good question and an important concern. I haven't read anything or I haven't heard anybody talk about denying care as a way to reduce the carbon footprint of healthcare. I think it's important for us going forward to figure out how we can continue to deliver high quality care to everybody who wants it and could benefit from it, but to do it in a way that's environmentally responsible.
Thank you.
Tim?
Thank you for this really excellent talk. I just wanted to pause for a second. This is important work, and the scale of the numbers is really staggering. And I love that you focused on the variation because there is some hope there.
Mhm.
Sorry, that was mostly just compliment, but there is a question in here. So, when I think about climate change, I think about occasionally people talk about these positive feedback loops where we melt the permafrost and we then release more, climate gases and we get even more heating. As I hear you talk about this, I wonder, heat stress and dehydration cause chronic kidney disease. I realize that the causes of chronic kidney disease are incredibly hard to study. But there's also this idea that chemical contaminants that may come from the petrochemical industry may cause chronic kidney disease. And this may all lead to kidney treatment, which then feeds back and causes more climate change. I wondered if you could speak at all to this possibility that we have yet another positive feedback loop to worry ourselves with. Not that that's a positive question, but it pops into my head.
Yeah, no, that's a good thought. It turns out there actually is an epidemic of kidney disease among people who have to work outdoors in hot conditions in South Asia and in Central America. So the heat stress is bad for the kidneys and can lead to significant and permanent kidney damage. So that's another thing that we need to kind of work on and try to figure out how we can protect people who have to work outdoors from the adverse effects of heat, including kidney disease.
Cool. So it sounds like from your answer, that's another way to intervene on the system. Like even if, if mitigation is possible, preventing the disease is another way to slow things down. Awesome. Thank you.
I see we do have a couple of things in the chat too. So Dr. Friedman asked, what % of hospitals are using green energy as a primary source?
I think as a primary source, it's probably close to zero, but as one of many sources, it's increasing, but still much lower than where it needs to be.
Mm-hmm. And then Rachel Summer has asked, from your perspective, how willing are hospital systems to engage in some of these waste and sustainability practices? And looking at how can the conversation be framed when speaking to those decision makers internal to the hospital administration as to what the cost benefit is for them to engage in these practices?
Yeah, no, that's an important question. I think that there's at least 3 ways to go to the hospital leadership with this. One is to just talk about the cost savings that could accrue to them if they shifted to cheaper renewable sources. The second is to point out that there's actually adverse health effects for the populations that they serve from continuing to use fossil fuels. And the third is that many people, especially younger generations, want to work for organizations that are environmentally conscious, and so that would be a way for them to attract good people to work at their organization. So I think that there are good arguments that can be made to health system leadership for why they should be shifting quickly to sustainable practices.
Thank you so much. If you have any other questions, feel free to unmute, or I'm moderating in the chat as well if you prefer to put your comments or questions in there.
Marcia.
Yeah, so I just want to mention, I'll say I'm a retired nephrologist and have a longstanding interest in home dialysis. And since transportation contributes, if my notes are correct, 25% to this, while we don't eliminate transportation because there has to be delivery of supplies and so on, I suspect, and I think it's worth studying, whether home dialysis would have another advantage, in my in my biased view, that home dialysis is a good thing for home dialysis. And home dialysis can be done through a number of modalities. There's others besides the one that Ash studied, but that's hemodialysis is the dominant one in this country. Ash, I have a question. There were 15, if I did this right, there are about 100 patients in the study? A year's worth of 100 patients?
No, it's actually about a year's worth of about 1,200 patients.
1,200 patients.
The numbers were the average per facility, not the total across all 15 facilities.
Oh, okay. All right. Thank you.
So let me
That
just
answers my
address your comment about the home dialysis. So it's possible for patients to have a hemodialysis machine at their home and do hemodialysis at home. There's another type of dialysis called peritoneal dialysis that it can also be done at home. In our study, we wanted to try to estimate the carbon footprint associated with those two types of home dialysis also, but there weren't very many patients in this particular system that were doing home dialysis. And we also didn't really have a way to capture some of the important data elements, such as electricity or water or natural gas use in everybody's home. So we weren't able to include that in this study. There was one group in, I think, Australia that looked at it, and not surprisingly, home dialysis does have a lower carbon footprint than facility-based dialysis.
So I'll ask another question if I'm sorry, JB.
That's okay, Marcia. Well, mine was pretty simple. Ash, in my experience in dealing with dialysis over 30, 40 years now, the mechanism hasn't changed much. It looks to me like the hydraulics and all are pretty much identical to what they were not too much after the darn thing was invented. Has anything been done on that? Because nobody worried about power or waste or anything at the time we came up with this thing. And I don't see much innovation. Is there anything on the horizon that would change the basic process of dialysis?
Not that I'm aware of. I don't know, Marcia, do you have any comments about that?
Well,
question?
yeah, I mean, so transplant is one solution. And there's a lot of work being done on growing kidneys that can be implanted. And an astonishing amount of progress has been made, although I think it's still far off from being an everyday reality for our patients. And there's also research work on sort of a biomechanical, if you will, synthetic kidney that could be implanted. So I think those are the main novel approaches. So I was going to ask, since 36% is electricity, Ash, would it be interesting to try to calculate the cost and benefits and payback period to put solar panels on the roof of every dialysis center, since the dialysis centers are usually freestanding community-based units?
Mm-hmm. Yeah, no, I think that would be a good thing to do.
There is a comment or question in the chat too from Rosa. Can you speak to the water resource usage of dialysis? So is this a concern or area for study in terms of water as a finite resource, not just the carbon footprint of it?
Yeah, that's a good question. So, I focused on the carbon footprint, but there's other scarce resources that are important and need to be considered, such as water. There's a lot of water that's used during dialysis treatment because that filter, the dialyzer, requires a lot of water flowing through it in order to adequately clean out the blood. So what could I say? I guess, yeah, I think it's an important topic that needs to be looked at, and but we didn't do that in our study.
And then Brenda has asked, if home dialysis is one of the solutions, what is the success rate of home dialysis compared to having dialysis, at a center? And will the lifespan of the patient remain equivalent to that, if compared to those conducted at like these facilities in the hospitals?
Yeah, so technically home dialysis is very similar to center dialysis. It's just, you're doing it at home instead of someone doing it for you at a center. So the expectation is that the outcomes would be similar. In fact, the outcomes are probably a little bit better, but that might be just because the patients who are able to do home dialysis are healthier and more with it than the patients who are getting dialysis in a facility. I don't know if Marcia wants to add something to that comment.
Thank you.
Yeah, I think that's fine. Thank you.
And then a comment from Christy. I'm so impressed by the thoroughness of this important work. I hope there are plans to analyze many more of these types of treatments and processes in the very near future, which I would definitely echo that. And I just am gonna, this has made me kind of think of something I learned, and I went to a conference recently about kind of highlighting the importance of incorporating climate change education into the medical school curriculum. I know one of our faculty affiliates, Dr. Karen Malloy, did a presentation on one of our seminars earlier this year about how I believe CASE is doing that. And then most recently in October, I went to a climate change conference at Ohio. I watched it from Ohio State, and there was a speaker, a fellowship director from University of Colorado School of Medicine, who they have a climate change fellowship program for their medical students or their residents. I can't remember exactly which one. So I would echo that comment from Chrissy that I think, making this a priority in medical school education and for clinicians kind of will also bring awareness to the problem itself, kind of circling back to Rachel's comment as well, is how do we get, how do we bring these issues to light for these, decision makers who are ultimately going to help influence, what we're doing to address problems. So yeah, I would agree. I really thank you so much for this wonderful presentation. And are there any other questions or comments?
I just have a quick comment. So if anybody's interested in using these techniques to look at some other process that you're interested in, feel free to reach out to us and we'd be happy to help you with that. I want to put in 2 plugs if I can. One is that I teach a course in the spring semester on climate change and health. And if anybody's interested in learning more about the course or sitting in on some of the lectures, please contact me. And then I'm also using my endowed chair to create a new faculty position that'll be focused on climate change and health research. And so if anybody's interested in learning more about that position, let me know about that also.
Great. Thank you so much. So I will be uploading. Does anyone else have any other questions or comments before we wrap up? Okay, well, I just wanted to say thank you so much again, Ash, for your wonderful presentation. The recording of this will be up on our event page as well as the slides. And I know that Ash's contact information was also in there as well. So yes, we just wanted to thank you so much for presenting at our last seminar of 2021. It's a great way to wrap up our seminar series.
Thanks for the great discussion.
Yeah. Okay, everyone, I hope everyone has a great rest of your Tuesday and rest of your week, and we'll see you soon. Bye.